Thank you, Mr. Zanga. Good afternoon to you all. I will do my best. So today I will be presenting a case of a combination of duodenal atresia and trisomy 21. So this is just building upon the discussions that we've been having on the importance of aneuploidy screening and the potential fetal defects that we may find, just to show you that these are practical things that we meet and are clinically relevant. So I'm presenting a case of a 27-year-old who was in a second pregnancy, and we saw her for the first time at 32 weeks. She had been referred from a local clinic after having gone for an ultrasound scan which showed polyhydramnios. So when she came in, just of note, she came almost 2 months after the referral. So when she then came in, she was complaining of low abdominal pain and backache, and she had associated dysuria. And of note, she was not perceiving fetal movements. Her pregnancy had been booked 2 days prior at the clinic, and there were no hypoglycemic symptoms, no diabetes screening, and because of that poor booking, she had missed aneuploidy screening. Anatomy survey had also not been done, and her first pregnancy was uneventful. On examination, she was otherwise normotensive, vitals were normal. However, she had mild respiratory distress and was complaining of significant abdominal discomfort. The abdomen was tense, it was non-tender. However, the hiatal fundus was quite large at 41 centimeters. The fetal parts were not palpable, and the fetal heart could not be heard with the fetoscope. On examination by the admitting doctor, they noted dilatation of 3 centimeters and membranes were intact. She had no show. They made an impression of preterm labor, UTI. She was admitted, sodium dexamethasone course, and an ultrasound scan was ordered. So the initial routine scan that was done, day 2 post-admission now, noted a singleton live fetus. The weight was 1,734 with polyhydramnios and abnormal Dopplers, as highlighted by Dr. Shliwayo. Reduced endostolic flow in the umbilical artery. MCA was also increased endostolic flow with notching in the uterine arteries. Recommendations were made for further testing. She then came for the specialist clinic in view of the polyhydramnios, and we noted that in terms of the biometry, she actually had an estimated fetal weight. So all parameters were below the 10th centile, and the estimated fetal weight was at the 7th centile, and the Dopplers were also abnormal. So this is just a few images to highlight the abnormalities that we noted. So initially we noted what we were terming the double bubble sign. So this is, sorry? Okay. So this is just the double bubble sign. It represents an image of the stomach and also the duodenum, the proximal part of the duodenum, and this middle part which showed the area that is atretic. And this next image is just highlighting the polyhydramnios, which was at 17.8 centimeters. And then we also noted, because we saw this fetal defect, it's also very important to then look for other fetal defects which might point towards a particular syndrome. So we also noted that the fetus had a ventricular septal defect, is highlighted here with the calipers, and also we noted there was an absent nasal bone. So due to the tense polyhydramnios and the patient's discomfort, we decided to do cervical length, and the cervical length that was done at that point noted that she had a cervical length of 2.8 centimeters, and the cervix was long and closed. So we went on to do amnio reduction. 3.4 liters was drained, and a sample was actually collected for karyotyping, because at this point we're concerned about trisomy 21. So the patient, however, 30 minutes later, as we noted some of the complications of amnio reduction, actually went into labor, had worsening contractions, went on to deliver a live baby boy within the hour, with an ABGA of 3 to 5 and 10, and also low birth weight of 1,600, and was admitted into the NNU. So this is just an image of the baby, just showing the epicanthal folds. Sorry, this is not showing the ears, but they also had low set ears, a flat nasal bridge, and also had a simian crease. So day 2 post-admission, they unfortunately had no NGTs available. However, they kept NPO and on supportive management. Day 5, they underwent a laparoscopic duodenal to correct the duodenal atresia. But however, the patient demised the next day. So, in general, with isolated duodenal atresia, we do tend to have good outcomes. 95% of these clients, neonates, actually survive. However, with our patient, there's a constellation of associated possible trisomy 21. There's also, there was the element of prematurity. There was also the element of low birth weight, and also this associated ventricular septal defect, which added to the complications that, the potential complications, and also succumbing to this procedure. So I'll just go through a quick discussion to note what would be the impact of trisomy 21 on duodenal atresia in terms of management and outcomes. Is there any difference to a neonate who might not have aneuploidy screening? So duodenal atresia is a significant cause of neonatal intestinal obstruction, and it occurs in 1 in 5,000 births. And duodenal atresia is actually associated with other chromosomal abnormalities, as we noted, particularly trisomy 21 that was suspected in this patient in 25 to 30% of the cases. And the global pooled prevalence of duodenal atresia in those with trisomy 21 is 3%, and there's no gender variation. As a solitary finding, the risk of recurrence in the next pregnancy is quite low. However, with association with other congenital anomalies, recurrence can go up to 50%. So association with other congenital anomalies is up to 50% of the cases. So it's also very important to screen for other anomalies, particularly the congenital heart defects, like we did for this client, and also other gastrointestinal abnormalities, because they might also have esophageal atresia. So these often then determine the overall prognosis, the risk of recurrence, mortality, and how you are going to then counsel the patient. And further investigations will be needed to characterize additional defects like an echocardiogram and also genetic testing. In terms of outcomes of duodenal atresia and trisomy 21, while the isolated one, like I mentioned, has excellent prognosis, when we have trisomy 21, it then alters the survival rate. Single-center studies have shown conflicting results, with some studies, one done in Thailand, actually showing higher rates of post-op complications and mortality in patients that have trisomy 21. And this was attributed as to our patient congenital heart defects and also respiratory tract infections. And those with isolated duodenal atresia were noted that the trisomy 21 diagnosis was actually an independent risk factor for mortality. In comparison, however, other studies actually noted no differences in these outcomes in terms of post-op complications and mortality. Like I said, there's conflicting data. However, a larger study, a population-based study in the UK, on the impact of trisomy 21 on duodenal atresia, its epidemiology, management, and outcomes, found that those infants who underwent surgery, cardiac anomalies were common in trisomy 21 patients, and associated GI anomalies were less common. And there was no differences in the type of surgical management that was offered, in the time to full feeds, in essential repeat surgery or mortality. However, there was a difference in hospital stay. So in terms of the role of early detection, Cohen noted that prenatal diagnosis resulted in earlier confirmation of the diagnosis, which was not done for our patient, and more appropriate care post-delivery. However, deliveries were noted to occur earlier with more prematurity and low birth weight. So timely prenatal diagnosis, it plays a critical role in enabling coordinated perinatal outcome and providing prenatal counseling and diagnosis. And this includes delivering at a specialized center and also availability of other specialties. So this planned approach helps prevent severe postnatal complications as such as electrolyte imbalances. In terms of management and prognosis, studies have shown no differences in the surgical management of patients with or without trisomy 21, meaning to say just because you have a client with trisomy 21, you say we don't offer surgery. So surgery still has to be offered, but of course knowing the potential outcomes that may come just because we have chromosomal abnormalities. So however, there is need for planned postnatal management strategies which would be important. For example, if an MDT had been done for this patient, if they had come in earlier, that addresses all facets of the patient's conditions. So this includes timing of surgical intervention, which typically should occur within 24 to 48 hours after birth. And in those with congenital malformations, a multidisciplinary team is required. And postnatal parental psychosocial support is also very important, as this woman did seem very traumatized after undergoing amnio reduction, eventually just going into preterm labor and the baby demising. So in conclusion, prenatal diagnosis of congenital anomalies with thorough screening of associated syndromes is pivotal in providing quick and comprehensive postnatal care. Thank you.